is a tricky subject because it always takes time for you to understand gait patterns. And if you look up the articles on gait and you look up textbooks on gait, some of the textbooks clearly describe what you should understand. As I said earlier, in the earlier part of my lecture, it is important to do sequential gait evaluations of patients with known diagnosis, watch their gait, how they are walking, go back, re-evaluate, come back and look at the diagnosis again. Is the X-ray picture correlating with the way he is walking? So this patient is walking, though he had a bilateral, significant arthritic hip, he was predominantly walking with the right side lunge. You could barely make out any lunge on the left side. So here is a patient with a significant arthritic hip, but walking with the lunge referring to the right side only. And that is because the pain component was the predominant component modifying his gait. And what you saw in his gait was a significant lunge to the same side with a significant reduction in stance space. So, to be able to assess the pathological gait, you need to understand normal gait first. The normal spectrum of gait has to be understood very clearly before you understand pathological gait. So you have to examine patients again and again, clinically, and look at the diagnosis. Go back and look at the gait again. That's the only way you can learn. So before you see the patient's X-ray, make an idea about what his diagnosis is likely to be. Then you look at the clinical examination, then you look at the X-ray, and then only you can correlate. Now remember, in a gait evaluation, you're looking at key components of the gait. And what are the key components? The key components of a gait is there stability in this particular person or not? Is the mobility component normal or not? Is there normal energy consumption in terms of motor for progression or not? So you need to understand different components. And human beings, when we became Homo sapiens erectus, we actually lost on the stability component right away, right in the beginning. A dog that is running can always outrun you. You can never outrun a dog because it's stable and it has got these quadruped position which is beautifully designed for speed. You can never outrun a dog. Remember this. Next time you're scared of a dog, you have to outwit it. Don't think of outrunning it because however fast you think you can run, you will be beaten by the dog. So it will outrun you and not catch up with you. So don't ever think you can outrun a dog. You have to outsmart it. There are beautiful illustrations on the net if you go on the National Geographic on this. How wild dogs, you can't beat them. Even on a bicycle you can't beat them because they're so fast. You can't beat them on a bicycle also. So you have to beat them in other ways. So when you go back, you can look up on the net how you can beat a pack of wild dogs even when you're on a bicycle. Okay, so you've lost the stability component, you've also lost the speed component because you became upright. These are the first footprints of human beings, of a bipedal human being. You can see this toe. This is in Africa, the first steps recorded in asphaltic ash 4.5 million years ago. And that's the time when we first became bipedal from the quadrupedal position. And if you saw the dog, it had bent knees. And what was the propulsive muscle it was using? It was using hamstring. And the expression hamstrung comes from that hamstring being pulled and the dog not being able to run fast because it can't use its hamstring muscles. So that expression comes from that original hamstrung, quadruped animals not being able to walk because the hamstrings are pulled. Because you should be quad-strung, not hamstrung. Because quadriceps is what is the last muscle that you have in your evolution. So a lot of times, question is asked, which muscle weighs first in any knee pathology? So wasting is always of the muscle proximal to the joint. So in the knee pathology, it's the quadriceps that wastes first. So the question was asked, why is it the first muscle to waste? Sir, evolutionarily it is the last muscle to appear. So what? So why should it waste first? Because the last few degrees of extension of the knee is done by the vastus medialis. The vastus medialis is the first muscle to waste. Why? Because in any knee pathology, if there is an effusion, if there is inability to use the knee, you can't extend it fully. When you can't extend it fully, that is the first muscle to waste, because the last few degrees of extension evolutionarily happened because of the vastus medialis. So you check for the vastus medialis wasting in your assessment of a knee. And as I mentioned earlier, your three components, stability in stance, means of progression and energy conservation. That is the most important thing. And when you're looking at a gait pattern, you're looking at these things. The most important of it is stability. So if you can't stand in a stable position, your gait is not possible to be independent. If a stability in stance is not there, you can't do bipedal independent gait. The other thing are the limb positioning. How is the limb positioning, pre-positioning? So if there's a deformity, pre-positioning is different. If an equinus, pre-positioning is different. Foot clearance. So if you have an equinus, again, foot clearance is not possible. The toes will touch against the ground and you'll have a high step increase. So foot clearance is important. The step length in neuromuscular conditions, the step length is important. A spastic child can't do a long step because hamstring are tight. A fascinating gait of a Parkinson's disease will take short steps. A person with the loss of position sense will have a broad-based gait. So depending on what is there, you will have the step length being modified. And lastly, human beings are designed to be lazy. We are designed to conserve energy because that is sustainable. Because if we didn't conserve energy, we wouldn't be able to survive long in the wild world outside. So it was important that all human beings have to conserve energy. So every gait pattern that we adopt must be energy conserving gait patterns. So you may walk with difficulty. With a lot of spastic child, we walk the same steps, but the energy consumption of a spastic child is hugely different from the energy consumption of a normal human being. So you need to understand these attributes. It is only for the sake of convenience of studying a gait that this distinction is made of stance and swing phase. It's only for the convenience of description and studying. Otherwise, gait is fluid, one merges into the other. You move from the stance phase to the swing phase, the swing phase to the stance phase. It's a fluid movement that happens, and for the sake of convenience, it's a stance phase which is described as 40%, the swing phase as stance phase is described as 60%, swing phase is described as 40%. In real sense, it's 62-38. Accurate measurements, they have found the difference is 62% stance phase, 38% swing phase. And each of the phase has a different group of muscles which is roped in per activity. So if you were to look at the stance phase, it starts with a heel strike, then foot flat, heel strike and foot flat, and then mid stance. But when you're doing this heel strike and foot flat, and then going on to mid stance, what is the difference between foot flat and mid stance? In foot flat, load bearing is not coming onto your limb. And therefore, if there is no load bearing on the limb, the quadriceps does not have to come into play. So foot flat, there is no load bearing, quadriceps does not need to function. That's the important part of foot flat and mid stance. Throughout mid stance, your quadriceps has to be active. So therefore, if I'm heel strike, foot flat, I'm moving on. Throughout this phase, the mid stance phase, your load bearing is happening and body weight is being transmitted until you reach the heel off stage, and then the toe off, and then you enter into the swing phase. Until that time, in the whole mid stance phase, there is load bearing. But there is a difference. And what is the difference? The difference is, when I am doing a heel strike, you need to know what is the different position of each of the limb states. And then next you move on to the swing phase. In the swing phase, the moment you raise your toe off, your swing phase is beginning. You have a stage of acceleration, mid-swing, and then you decelerate till you heel strike again. So that's one step. But they tried changing this description into a more symmetrical kind of a description in terms of stance and swing phase, a phase of weight acceptance, single limb support and limb advancement. Initial contact, loading response, mid stance and terminal stance. Unfortunately, this did not become popular, but for theoretical hardcore gait analysts, this is the expression that they use for describing gait. But if you remember, the stability component comes from your structure, your ligamentous integrity and your muscle function. Assuming those are intact, then you look at the pre-positioning. How is the limb positioned? So if you have to describe pathological gait, you need to know in various positions of the gait cycle, what is the position of each joint. So at heel strike, the ankle is at 0 degree to the tibia. That is it. The knee is about 5 degrees flex, it's not completely extended, and the hip is about 25 degree flexion at initial contact. So if a patient has got a flexion deformity of the knee joint, obviously the pre-positioning is affected. So you need to understand this. If he has a flexion deformity of the hip, again pre-positioning is affected. If there's a hip flex, the knee automatically flexes and the ankle automatically goes into equinus. So he cannot have a heel strike position. So when you say a normal gait pattern, you have to say bipedal independent gait, hip knee flexing normally with a normal heel to toe progression. So the normal gait cycle has a normal heel to toe progression, and that heel to toe progression is a normal pattern. The moment the pre-positioning is not possible, the heel to toe pattern cannot happen. So you need to understand that. The loading response. So now when I am doing heel strike, the ankle is in neutral position. It's not in plantar flexion. From there it goes into foot flat. When it goes into foot flat, it's gone into plantar flexion. So it goes into about 10 to 15 degrees of plantar flexion to foot flat position. So that's position, there is no load bearing. From there on, what is happening? I am moving forward. The foot is in the same position. I am moving forward. So what is moving forward? The tibia is tilting. So you have to understand this. The next position is 10 degrees of plantar flexion there and 15 degrees of flexion there and 25 degrees, about 20-25 degrees of flexion there. And as you go on to mid stance, this now moves on to slight 5 degrees of position here, 0 degree here, almost 0 degree here. So if you watch here, heel strike, foot flat, that's 15 degrees of plantar flexion. And as my tibia comes over the top of the dome of the talus, my body is also coming on top. CG is also coming in front. Remember, CG was behind here. CG is now gradually moving closer and closer to the axis of knee joint till it comes in front of the axis of the knee joint. So towards the end of my stance phase, I don't need my quadriceps to function at all. It is alignment stabilized. Initially, I need a lot of quadriceps functioning because there is a gap between the axis of the knee joint, the weight bearing is behind. As the axis gets closer and closer to the load bearing area, line of load bearing, the need for quadriceps goes down till it has come in front. The load is in front, it is alignment stabilized. So that's what happens. You have this as a component. So you need to understand this need for the quadriceps mechanism to function, maximum in the early part of mid stance, minimum towards the end of the mid stance. So that's how it is. So you need to know the positions. In terminal stance, it's 15 degree, 10 to 15 degrees of extension, 0 degrees of the knee, 10 degrees of plantar flexion. So it's coming up into plantar flexion. And then towards the swing phase, it's now in maximum plantar flexion. And as it is, at that stage is now to be lifted up. So you have your dorsiflexors coming into maximum action just around this stage. The dorsiflexors of the ankle, if tibialis anterior is not functioning, it will not function. So you have to have dorsiflexor coming here and the knee goes into flexion. The maximum flexion that normal knee joint needs is only about 60 degrees of flexion. So if a person has got a 60-degree range of motion, he can have a normal gait pattern. Don't worry, he doesn't need to have a 90-degree gait, knee flexion to have a normal gait pattern. Just with 60 degree, he can have a normal gait pattern. That's the importance of this understanding of the ranges of movement in different swing phases. So swing phase is 25, 25, 0. So hip range, you don't need more than 25, 30. That is why the position of arthrodesis, you don't need to have too much of flexion or too much of extension. About 25, 30 degrees of flexion is sufficient as a functional position for arthrodesis in the hip joint. In terminal swing, again, you come to the same position. So if you see, if I were to go back to this clipping and follow this sharply, it will look as if this cartoon figure is moving. I'll move it quickly. Doesn't it look as if it's moving? That's what happens in an animation. In an animation, you do this in a manner so it simulates normal walking pattern. So you simulate the range of movement of the hip, knee and ankle, and you can simulate normal gait pattern. Again, if you see, when I start heel strike, at that point my heel is not moving, it's stuck at one ground, but my whole trunk is moving forward. So there is a rocking movement on the heel. So that's the first rocker of your gait cycle. First rocker. The second rocker comes after foot flat. Once the foot is flat on the ground, the tibia rocks on the dome of the talus. Now, this movement throughout the mid-stance phase is rocking of the tibia on the dome of the talus. That's the second rocker of your gait cycle. The third rocker comes when you're beginning your toe off. You see that the metatarsophalangeal joint, there is a toe off that is happening there, and that's the third rocker. So in any gait cycle, in the stance phase, there are three rockers. The heel, the dome of the talus, and the first metatarsophalangeal joint and the metatarsophalangeal joint of the other toes. But predominantly, it's the first metatarsophalangeal joint. So the three rockers have to be clear and functioning in a normal gait cycle, which means if you have an equinus, first rocker is not operational. Second, if you have an ankle that is arthritic and stiff, the second rocker is not operational. Third, if you have an arthritic MP joint from uric acid and gout, again the third rocker is not operational. So your gait is going to be altered in the stance phase in all these. So your mid-stance component is affected in these three cases, and if there is an equinus, your heel strike itself, the first rocker itself is gone. So you need to understand the mechanics of this. So how do you do observational gait analysis? You do observational gait analysis, you have to watch minimum 15 steps. Get the patient to walk 15 steps one way, turn around, other way, back and forth. 15 steps you do, and then watch him from front, side and back. So you need to look front, side and back, 15 steps minimum, to be able to have some understanding on what is this gait cycle. You may need to do it several times, and when you're doing this, you examine from head, shoulder, trunk, hip, the pelvis, the knee, ankle and the foot. Go back and forth. So you may need to do this several times before you can have a judgment on what type of gait it is. And you need to describe gait first. So you describe what is the pattern of the gait in this particular. Watch specifically the foot, the ankle, the knee, hip, trunk and shoulder, how it is moving. So the gait analyst would talk about the hat segment, head, arm and trunk segment. So in a CP child with a hemiplegic gait, the arm segment will not move normally like the other. That would be the first clue that it is a hemiplegic child. The associated movement of the arm will not be there. So you need to look at the head, arm, trunk, the hat segment, how is it moving, and how is the lower pelvis and the lower limb segment moving. So you need to study this carefully before you to come to a conclusion of how is it moving. So you look at the speed with which the person is walking, look at the stability component. If he is not stable, he'll need a stick, he'll need a crutch, or he'll need a walker, whatever. Is it consistent, or is his gait pattern changing? Is the step length short or long? Short steps I mentioned in Parkinson's, long steps I mentioned. It's not possible unless the hamstrings are lax enough. An associated movement of the upper limb is equally important. Again, a lot of people don't understand this. This is very important in the CP child. You need to understand in quiet standing, there is very little. Remember I said human beings are designed to be lazy. We are designed to conserve energy. So in quiet standing, the hip joint, see remember, hip joint bends forward. So if my axis of weight of the center of gravity is in front of my hip joint, my hip will buckle like that. The knee joint bends like that. So if the axis is behind the axis, if the weight bearing line is behind the axis of the knee joint, the knee will buckle like that. And if the weight is falling in front of the ankle will buckle into dorsiflexion. So remember, the natural tendency, if the weight bearing line is falling in front of the hip, is to bend the hip. Behind the knee is to bend the knee. In front of the ankle is to dorsiflex the ankle. That's natural tendency. But in quiet standing, look how nature has done it. Nature has done it brilliantly. In quiet standing, the weight bearing line is just behind the axis of rotation of the hip joint. So you don't need any muscle to stabilize that. In quiet standing, the weight bearing line is just anterior to the axis of the knee joint. So you don't need any quadriceps. So when the knee is in quiet standing in a locked position, you don't need any quadriceps functioning for standing quietly. But what happens is, something is amiss here. The nature did that. Nature did that. The weight bearing line goes in front of the axis of the ankle joint. So what happens? When it goes in front of the axis of the ankle joint, there is a tendency for the ankle to go into dorsiflexion. There is only one muscle that is required to prevent. So in quiet standing, in only one muscle activity, and that is the soleus. That is why it is such a critical muscle in your lower extremity. In a CP child, it's the most critical extremity muscle, and therefore you would not like to fiddle with the soleus in a CP child because it is so important for standing. And therefore, you do not do a TA lengthening, because the moment you do a TA lengthening, you're affecting the length of the soleus, you're affecting the ability of this child to stand independently. So you do not want to tinker with this, because in standing, this is the most important muscle. So in quiet standing, with the least energy expenditure, this is the most important muscle. However, the moment you do this, axis of weight bearing is behind, you have to have the quadriceps coming into full action. If your quadriceps is not there, you cannot do this activity. So you need to understand that. Again, you have marathon walking and you have marathon running. So when you ask the question, what is the difference between walking and running? In walking, there is always a period of double stance in the gait cycle. So at no time are both my feet off the ground in walking. So when they video record these Olympic walkers who are marathon walkers, that's what they look at. Are they walking fast or are they running in between? So the running has to have a double swing phase. Walking always has a double stance phase. So in running, there is a position when both the feet are off the ground. In walking, both the feet are never off the ground. So that's the difference between walking and running. There is a period of double stance in walking, and there is a period of double swing in running. So this has to be clearly understood. Double swing is important in running. Observational gait analysis has its fallacies. In some tricky cases, especially spastic children that are walking, especially other neuromuscular conditions that are walking, it's very difficult even in the most experienced hands. Therefore, we do instrumented gait analysis. Instrumented gait analysis takes advantage of video recording. So you have videos placed on the back, on the front, on the sides. Now, you may not be able to critically evaluate the way the joints are moving. So what do? They put markers on different joints and then see how reflective markers. So when the videos are recorded with lights on, the reflective markers appear as bright points which move in space, and on top of that you have what are known as force plates. Force plates allow you to show the distribution of weight on different parts of the sole on your normal walking cycle. So the force plate is one component, the video recording is the other component, the markers on different joint surfaces is the third component. This is a video which I have borrowed from Reinhold Brunner, and this is a CP spastic child that is walking. You can see that you're watching it from the front. The normal heel to toe progression is not there. The short steps, the knees are kept in flexion, adduction, internal rotation on the right side. So you need to know how this pattern of walking is possible. So you see the same child from the side. It's another child from the side. So you, in the instrumental gait analysis, you do this kind of an evaluation from front, side and back, and you watch what is the hat segment positioning, what is the pelvis doing, what is the hip movement, what is the knee movement, what is the ankle movement, and you get to a conclusion of what is affecting. You also look at the EMG recording. You can have telemetric recording from the muscles to see in which part of the phase of the gait cycle which muscle is started firing. So you can make out from the gait analysis, which is instrumented, which muscle is overactive, which muscle is contracting concentrically, which muscle is contracting eccentrically. Now this is some term which a lot of people have difficulty in understanding: concentric contraction of muscles and eccentric contraction of muscles. Let me explain. I am climbing this flight of stairs. I am climbing down this flight of stairs. So in this position, my knee is bent. To climb up, I have to contract my quadriceps actively. That's a concentric contraction of my quadriceps. Okay, now the same step I am climbing down. Okay, what is happening? I need bending of my knee. Which muscle is important for bending? I need hamstrings to bend. But if hamstring were the only muscle functioning in this position, would I be able to get down? No. What has happened here is there is a controlled contraction of quadriceps with a controlled relaxation. So that is known as eccentric contraction of the quadriceps. A lot of students do not understand the difference between concentric contraction and eccentric contraction. This is a classical example. In climbing upstairs, you have concentric contraction of quadriceps. In climbing downstairs, you have eccentric contraction of quadriceps. So that is what you have. And in gait analysis, you look at which muscle is acting in which phase. In stance phase, what are the active muscles? In swing phase, what are the active muscles? So in swing phase, you predominantly the foot muscles that are active, and in the stance phase, you have predominantly the gastrocnemius, the peronei, all these other muscles that are active. But remember, soleus, and this is the normal recording that you get in a gait analysis computer recording. This is how you get it. And if you look at children that are presenting with the gait analysis chart, this is how it will be. But a precondition to be able to do a gait analysis, which is instrumented gait analysis, if the child needs to be supported by somebody and needs help in walking, you can't do it. So independent walking is a precondition for the child to have an instrumented gait analysis. So it's important for you to understand this, that when you refer a child for gait analysis, the child should be able to do independent walking. Otherwise, you can't do a gait analysis that is instrumental. But eventually, when you're looking at your energy cycle consumption, what is aimed at by nature is minimal movement of the pelvis. Minimum elevation, minimum mediolateral movement of the pelvis, so that is why in a bilateral waddling gait, you have energy consumption that is higher than normal. Any movement of the pelvis up and down, any movement from the side to side movement increases the energy consumption. So nature has designed it in such a way that the energy consumption is the least. So we have to plan it by looking at how the heel move, the pattern of the lower limb movement affects your pelvis movements. Also, if you look at the way the gap between the normal is about 5 to 10 centimeters between these 2 points, the centers here and centers here, it's about 5 to 10 centimeters. A person who has got unstable gait, whether it is an ataxia from cerebellar lesion or an ataxia from a posterior column disease, the person will try to increase the stability by broadening his gait pattern. So this distance between the 2 feet is important for you to understand. Normal is 5 to 10 centimeters. Again, every time the pelvis moves up and down, you have more energy consumption. So you need to know there is a cyclical change in the energy consumption. So the gait that is abnormal will be abnormal because of anything in the stability component, anything in the progression motor component, and anything in the energy conservation that is there. Also, any pain producing thing will alter your gait pattern. So pain can be anywhere, starting from a thorn in your heel or a painful arthritic hip. You will have what is known as an antalgic gait. Now, antalgic gait, there's a lot of confusion. A lot of people come to me and ask me, "Sir, what happens in an antalgic gait? Lurch? Do they lurch in an antalgic gait?" In an antalgic gait, you try to reduce the amount of pain in your body. How do you reduce that? By reducing the exposure. How do you reduce the exposure? You reduce the time for which the foot is on the ground. So stance phase is reduced. Swing phase, there is offloading. There is no pain. So you don't have to worry about the swing phase. So stance phase is reduced. So remember, stance phase is 62%, swing phase is 38%. So if you have a person who is walking, correspondingly the swing phase gets prolonged. The stance phase on the opposite side gets prolonged. The swing phase gets prolonged. Naturally, because the stance phase is getting prolonged, the swing phase is getting prolonged, the stance phase is getting shortened. The stance phase is shortened. That's the first precondition for a antalgic gait. Stance phase. When you say a painful gait, antalgic gait, you have to show the examiner that there is a shortening of the stance phase. So that is what you have to show. The lurching can happen to either side. Let's look at the situation. In a normal pelvis, that's the weight bearing opposite S2, 1 inch in front, you have the center of gravity. In a perfect quiet standing, it's beautifully balanced, equal distribution between the 2 hips, quiet standing, equal distribution of weight between the 2 sides. 50-50, 60 kg man, 50-50, 30 on either side. Is it 30? No, it is not 30. Something else is 30. In quiet standing, this hip and this hip, both are eccentrically loaded. Eccentrically loaded. So there is a weight here, but there is a lever arm here. It's about 15 centimeter lever arm from here to here. That's a wide lever arm. 15 centimeter lever arm multiplied by 30 kg is a multiplication factor. So there is a multiplication factor there. So there is, the moment there is a lever arm, there is a couple that happens. So there is a load here with a fulcrum here which is trying to tilt this pelvis to this side. When this tilting has happened, there has to be a counter, and that counter is provided by the abductors. So the abductors provide the counter. So now, on the same hip joint, in addition to 30 kg of one side hip that is happening, movement that is happening, there is a multiplication factor that is happening. In addition, there is a balancing of the moment of couple that has happened, that is abductor contraction also. So in quiet standing, the load on the hip is not just the body weight. It is in addition to body weight, a multiplication factor to the lever arm, to the abductor mechanism that is there, and therefore the total load is more than the weight that you anticipate it to be. And particularly in load bearing, it is estimated to be at least about 1.5 to 2 times the body weight in a normal human being. So you have, in a 60 kg man, the weight is much more than the body weight of that human being. That is why your hip joint, when you do fixation for fracture neck femur, trochanteric fractures, you imagine the stainless steel implant, titanium implant, it breaks. Why? Because the loading is so much, and especially when you are walking, in walking the load comes to 2 to 3 times. 2 to 3 times in a human being who is 80 kg will be almost quarter of a ton. And in running and climbing stairs, remember in climbing stairs, the lever arm is far more. So 45 centimeters is the length of your average femur. So 45 centimeter with an eccentric loading of the whole body weight behind you, the total multiplication factor is huge. So you do not allow hip patients who have had undergone surgery for the hip to do staircase climbing without support within 6 months or so until you are sure that it is reasonably healed. So that is the reason, because of multiplication factor. Coming back to this, there are two possibilities. In this hip, if you have a painful hip, right side painful hip, stance face is reduced. So what do? I do this. Most of the time I'm standing on this side, but little bit support to get on that. Stance face is reduced, that's a painful gait. So I could lurch to this side or I could lurch to this side. Let's assume I lurch to the opposite normal side. So this is the affected side, I lurch to this side. Let's see the mechanics of it. Go back to the computer picture. Let's see, if I am lurching to the opposite normal side, let's see, I am standing on this side, I am leaning onto this side. What happens? No, go back to the here only. See that? The CG is now moving away from this hip joint, the lever arm increases. For the same body weight, when I lurch to the opposite side, the lever arm is increasing. Simple elementary high school physics. When the lever arm increases, the moment of force increases. When this moment of force increases, this poor abductor has to put more contraction to prevent the pelvic tilt. So this increases, this also increases. So there's a double problem there. The moment increases, momentum increases, the abductor mechanism has to work more, and overall more weight comes on this hip joint. What is the aim? To reduce the weight on this hip joint. It is a painful hip joint. What did he do? On doing this, I actually increase the weight on this. So intuitively, patient doesn't have to be told, you lean to this side or this side. No, he'll do it on his own, because he learns. When he learns to this side, let's see what happens. When he leans to this side, the body weight now passes more close to the fulcrum. And therefore, this lever arm is now shortened from 15 centimeter, maybe even 6-7 centimeter. It comes very close to the top of the head. And therefore, the moment arm that is generated is less. Therefore, the abductors have to act less. And therefore, the net load on the hip is much better. So, in an antalgic hip gait, always lurch to the same side. So, I have a reduced stance phase, but I also lurch to the same side as in that patient. So that's the biomechanical explanation for lurch to the same side in an antalgic hip gait in a patient. Now let's look at the walking stick. So assuming I have a hip pathology on the right side, and this is the walking stick I have. Right hip is affected, so I could use the walking stick on this side, or I could use the walking stick on this side. Let's assume you tell the patient, right hip mein doctor sahab kaun se haath mein pakadna hai, which side should I hold my stick? You tell him the same side as your pathology. Okay, so I tell him to use it on the right side. So let's see what happens. Right hip pathology, when I am putting weight on the right side, I put the stick on this side. So when I put the stick on this side, what am I doing? I am pushing the ground with a small fraction of force with my hand and pushing the ground. Newton's third law, there's an equal ground reaction force that comes up. What does the ground reaction force do? The ground reaction force is pushing my hand and my trunk to this side. So it pushes my trunk to this side. When it pushes the trunk to this side, lever arm increases, load increases, abductor force increases, I have more pain. Whereas, when I have on the normal side I am using my stick, when I am standing unsupported, this becomes the second leg support. So it neutralizes body weight on this side. That's the first part. The second part is it helps me lean to the same side. When you help lean to the same side, Lever arm is reduced, abductor force is reduced, net force is reduced, and I have more comfort. So intuitively, even if you told the patient wrongly, he will pick the stick on the side that is more comfortable with, and that is the normal side. The walking stick is always on the normal side, not on the affected side, so you have to remember that. And it's a simple biomechanical evaluation. Now let's look at Trendelenburg gait. In Trendelenburg gait, again, in this, let's take away the pain component. There is no pain. Let's look at a person with a developmental dysplastic hip on one side. Right side is a dysplastic hip. So the abductor mechanism is inefficient. If the abductor mechanism is inefficient, same logic. You lurch to the same side to increase the efficiency of the lever arm. You reduce the weight, body weight, you reduce the multiplication factor, you reduce the load on the abductor mechanism. So you naturally lurch to the same side, so I'll lurch to this side. But here the difference is the stance space is not reduced. It can be a lurching with stance space reduced where there could be an instability component also. So it could be a painful gait. So you have this. All that you can say in a short stance space lurching gait is it's an antalgic gait. However, it's no reduction in stance space. You can say it's a gait with lurch of the trunk to the same side, and there is no reduction in stance space, normal equal stance space component. So in a classical Trendelenburg gait, you have that as a feature, you have lurching to the same side. Here is a patient with the DDH, with the lurching to the same side as the affected side. Here is another patient. She has had a girdle stone hip arthroplasty, excision arthroplasty with a shortening. She is wearing a shoe race, and she doesn't have an antalgic component. She is lurching significantly to one side. Now, when you have an excision, in the gait pattern there will be one more component. It may not just be an abduction lurch that is there. It may be in addition, in proximal arthritis patients particularly, when there is total neck and head is gone, they may want to compensate for the hip problem also. So what do? They do this. They'll go back also. In addition to the side, they'll go a little back also. So you need to understand they're compensating for the hip extensor, they're also compensating for the mechanical inefficiency of the abductor mechanism. So that's what it is. So this is a patient, there was a girdle stone excision arthroplasty. Now here is another patient who had a girdle stone excision arthroplasty, but a pelvic support osteotomy was done. So the amount of lurch that they have is a little less. Now she had a severe lurch, both abductor and extensor, when she came. This is after the pelvic support osteotomy. The degree of lurch had substantially reduced. So you need to understand this is able to reduce the swaying of the trunk. Any swaying of the trunk is energy intensive. We want to reduce the energy intensity of the thing. In addition, like the little girl that was presented in the morning, she had that plus a short limb. How do you decide that the shortening of the limb and a short limb gait? When the trunk goes up and down. So you need to describe the head arm trunk segment vertically dips every time weight bearing is done on that. So the classical position, I'll demonstrate that here. People say, if you have a lot of shortening, you will sway. No. Even if you have a lot of shortening, you are not going to sway. You only dip vertically. Watch me. This is like, this leg is long and this leg is short, isn't it? So, it's only a vertical dip. Supposing I were to increase the shortening, this is the discrepancy, this is the long leg, and that's the short leg. It's a vertical dip only. It doesn't cause me to sway my trunk. Swaying of the trunk has to be because there's an abductor inefficiency, because there is a pain which is wanting me to reduce the mechanics of my hip joint. Is that clear? Because some students in the exams here, there is a severe shortening, therefore he is lurching. No. I have shown you this is a severe shortening. It's almost a foot difference in the length of the 2 feet. So that is the way the body works. There's no lurch that happens. So in a short limb gait, there's a vertical dip with no lurch. You may have a combination. I don't think this video is working. Now in arthritic gait, the pain and the restriction of movement causes problems. The pain depends on where the pain is and how is it affecting the pre-positioning. So you can't have a one description for an arthritic hip because depending on how many joints are affected, what is the range of movement, what is the deformity. So an arthritic hip gait would basically be depending on the positioning, pre-positioning deformity number 1, number 2 range of movement in that, and number 3 the degree of pain that the patient has. So there's no one formula for an arthritic hip joint, but the velocity will be decreased, the cadence, the step, the way the 2 steps are taken, that will be reduced, and the stride length will be reduced. So you have elderly patients who are arthritic, but they also have poor coordination and poor balance. They will not be happy walking on smooth floors. They'll be happier walking on carpeted surfaces because the resistance to slipping is less there, so they are more comfortable walking on carpeted surfaces. They'll not be more comfortable walking on tiled floors. So it's best to have not too smooth surfaces for these people. They'll have, because they're arthritic, they'll take short steps. Because they have poor balance, they may be little broader steps, short steps than normal, and to reduce the amount of energy, they'll reduce their center of gravity to improve the balance. Balance improves with lowering of center of gravity. So they might hunch down basically because they want to improve their balancing. So if there is a patient who has got a paraplegic, D11, 12, complete paraplegia, complete sensory loss, he will look down when he is walking and he'll have a broad base gait. Why? Because the complete sensory deficit is compensated by visual images. So he doesn't know where his limbs are until he looks down. So a person with a Romberg sign positive, so a very common mistake is to think Romberg's is because of cerebral ataxia. No. Romberg is posterior column disease, not cerebral ataxia. Romberg's positive means ask the patient to stand with the feet close together, ask him to close his eyes, he will immediately stagger down. That's a posterior column integrity test. So when you're checking for posterior column, you do this and then you see these patients will walk with a bilateral, broad-based gait, and if he's got a paralysis, both lower legs are paralyzed, bilateral will be high stepping because the feet tend to drop down. The dorsiflexors are not functioning. So bilateral high stepping gait will be there in these patients. So that is a broad-based ataxic gait that you have. Parkinson's disease, you have 2 components there. One is the balance component, which is poor. Number 2, the muscle tone is high, hypertonic muscles. So therefore, if your hamstrings are tight, which is a primitive trend, most spastic children have hamstrings tight. So you have inability to straighten you. Your ability to stretch your leg out is because your hamstrings are able to relax. You can't do that if your hamstrings are tight. So if your overall tone is high, you take short steps, very short steps. So CP children take very short steps. Parkinson's patient with hypertonicity, extrapyramidal, they take short steps. In addition, they have a balance problem. So when they have a balance problem, they do this and they take short steps. Again, remember, your balance depends on 2 things. One is your movement. 2 is your center of gravity. A center of gravity that is high, your poor balance. So most people that have poor balance tend to stoop down because they want to lower the center of gravity to improve their balance. Number 2, you would find that's happening with a lot of CP children. They'll walk fast and the parents would complain, you know, Dr. Saab, he doesn't walk slow at all. Remember, a coin that is rolling, as long as it is rolling, it's okay, it stays vertical. The moment it begins to stop rolling, it starts falling down. So bicycle, moving fast, it's stable on its own. Slow cycling is more difficult because you need more balance. Because that movement dynamic itself provides a degree of balance. It's the movement dynamic which is causing balance. So you need to understand that. So if the person is walking fast, not because his balance is good, because balance is poor. So festinating, festinare, the word means hasten. So a festinating gait is a classical description for a Parkinson's gait. They'll walk with short steps. He'll walk like that, as if he's falling forward like that, and he's trying to catch his own center of gravity. Festinating gait, a festinare gait. That is gait. Arthrogrypotic gait, they have stiff hip, stiff knee, stiff ankle, and therefore they do not walk the normal gait cycle patterns of the hip flexion, knee flexion, ankle, all that. So what do? They then use their trunk. Their trunk movement is like that. They're not using their leg, they're moving like that. Now go and watch Animal Planet or National Geographic or Discovery Channel and watch the March of the Penguins. Huh? You can find it on the net also, March of the Penguins. It's in Melbourne, they have a sightseeing trip on March of the Penguins. Huh? So you can do that. So when you see the penguins walk, they walk like this. So it's arthrogrypotic penguin gait because hip, knee and ankle all are stiff. Cerebral palsy, the problems are there is abnormal timing of muscle activity. So when you want the hamstring to relax, they don't relax. When you want the quadriceps to contract, they don't contract. When you want the dorsiflexors to act, they don't act. Is the plantar flexors active? Gastrocnemius is overactive. So that causes problems. There is a loss of stance phase stability, therefore they will crouch down. And there is also loss of swing phase clearance because of the equinus, the ground clearance is not there. So they have multiple problems which contribute to their gait patterns, and that takes a little while for you to understand. Commonest are diplegics who normally walk by around 4 or 5 years. They tend to walk faster, I've already mentioned that. And usually they have what is known as in-toeing of gait. Normally, normal human beings, I mentioned it's about 10 to 15 degrees of extorsion that is there. They walk like that. That's normal. But you sit at a busy bus stand or a railway station and watch people walk. A small percentage of will walk with their feet pointing forward. A still smaller will walk with their toes pointing inwards. That's pigeon-toed gait. Classical pigeon-toed gait is described when there is excessive femoral anteversion. Anybody with a delayed walking pattern, CP children particularly, have a tendency for the normal anteversion at birth to persist for a longer period, and therefore they walk with a pigeon-toed gait. So anybody with a pigeon-toed gait, think for an excessive femoral anteversion. There could be other causes also for it, which you need to assess. Look for the good thigh angle, look for the dorsal tibia, look for femoral anteversion, look for other things. But the primary thing in a pigeon-toed gait, you must do a hip examination, leg examination, a foot examination, all are important. So pigeon-toed gait is what it is. On the other hand, the reverse is also possible. You may have an extorsion like that, and that's a Charlie Chaplin gait. The Charlie Chaplin gait, completely externally rotated, which can happen in a retroverted femoral head. So you can have a version problem, reverse of anteversion. You can have the same Charlie Chaplin gait possibility. Now that's a cerebral palsy child with a classical scissoring. Now scissoring, you can describe it in two types. A true scissoring like you have in this, crossing over of one leg or the other, crossing over. So it's a supported scissoring gait with severe adductor spasm in a child who's got a supported walking only. So that scissoring pattern, you have to differentiate from this true scissoring, from pseudo scissoring. Pseudo scissoring can happen when you have both the hips flexed, both the knees flexed, and both the limbs are an external, both the knees are coming together. But see the difference between the two. In this, there is a true crossing over. In this, in pseudo scissoring, my feet are apart like that. So I have to distinguish between pseudo scissoring and true scissoring that you see in some of these patients. So if you go and you see a patient walking like this and you end up doing an adductor tenotomy and an adductor urectomy, you will be in trouble with that child. Hemiplegia, the stance phase is prolonged, more of double cert is there, support is there, equinus is increased, decreased flexion of the knee and increased flexion of the hip. So that's, you have associated movement of the trunk is not there, associated movement of the hand is not there. See from the behind. So you have to see from front, you have to see from behind. See, the normal heel to toe progression is not there. Heel is constantly off the ground. The hip flexion, knee flexion is more because the ground clearance is not possible because of equinus. So when you look at this child, you look from head to toe. You look at the arms are not having associated movements. See, let's look at the next side view. See that? There's a high stepping gait, more flexion of the knee, more flexion of the hip, and lack of associated movement of the hands. So that's a hemiplegic gait. Another hemiplegic child. See this? Now, recurvatum deformity is one crippling deformity which can create problems in walking. So, you must try to avoid recurvatum in these children at all costs. So, particularly cerebral palsy children, a lot of times it can be iatrogenic recurvatum and you must avoid this, and recurvatum causes problem. Though it causes stability, every time the knee goes back, the whole trunk goes down, and then to get it up and out is a tedious exercise for these children. So recurvatum gait is a problem many of these children. Foot drop is a high stepping gait. They stamp their foot down. This is a paralytic foot drop. She goes up and down, high stepping. You can hear the tuck 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 that she is doing. The high stepping gait because of paralysis of dorsiflexors. Again, in equinus, normal heel to toe progression is not there. That's a spade foot walking. Yeah. Calcaneus deformity, it's a peculiar gait pattern. You must recognize calcaneus deformity because you may get a case with spina bifida with a calcaneus deformity. In the normal gait cycle, the push-off happens from the gastrocnemius. So this push-off phase will be missing in the calcaneus gait. What do? They'll have lack of push-off. They just put their foot down and then walk. They just lift it up, put it down, lift it up, put it down, lift it up, put it down. But no push-off, no heel to toe progression like that. So calcaneus deformity gait is a very, very typical gait with a lack of push-off. Now this is a very important part. If you remember, that's it. Quadriceps paralysis. When there is quadriceps paralysis, you have this pattern of gait. When the quadriceps is paralyzed, at heel strike nothing happens, at foot flat nothing happens. The moment loading happens in mid stance, the quadriceps has to function, otherwise it will buckle like that. To prevent that buckling, you push your thigh back with your hand. Hand on thigh, push it back, keep it back from buckling till you get your CG in front of the axis of the knee joint. Then you take it off. You do it again, take it off, do it again, take it off, do it again, take it off. So that's a hand on thigh or a hand on knee, or as they get older, they get conscious, they put their hand in their pocket and do this. They'll push their thigh with their hand in their pocket like that, and that's a hand on thigh gait to compensate for a failed quadriceps mechanism in the mid stance of the gait cycle. Crutch patterns of gait, I think I'll take it in the orthos. I'll stop here. Any questions?